funds, thinking about investing in capital investment in the National Health Service. The important point is that the projects are procured through open competition. There is competition for who will run these projects, which does hopefully drive out the excess costs that might be there otherwise. So there are advantages and disadvantages of these projects. I want to just go through these quickly. Obviously, what you get is good access to capital and expertise. The expertise is very important, particularly when it comes to the third point there, the quicker delivery of projects. They are on time and delivered on time and delivered on budget because of the expertise which the PFI project brings. I've mentioned already the transfer of risk. So the private sector, the private providers, have to take responsibility for construction overruns if there are any, and other risks that go with all this. And there are performance efficiencies too over those years from the private sector management, which has very clear and transparent accountability because of the agreements that are made. And they do get very high scores for service performance and have improved the way services are delivered in the National Health Service over time. So those are the advantages. But of course, there are disadvantages too. It can be quite a lengthy procurement process. The competition to provide the right provider can be very lengthy and bureaucratic. I've already mentioned the lifetime costs, which are high. And of course, particularly when there's been a squeeze on the budgets of hospitals with PFI bills to pay in the recession, there have been particular problems for them to find the money without losing jobs. And some would argue there's a bit of a loss of direct control of the National Health Service to the PFI company. And of course, there are cultural tensions between a private provider sometimes and the National Health Service. So pros and cons, but it has led to 120 new hospitals which people feel would not have been built, which are very well organised. And here's one. It's one which Mike Sexton mentioned in his health information talk. This is the new Queen Elizabeth Hospital in Birmingham, a big PFI project run by Balfour Beatty. I should just very briefly mention smaller projects in primary care. These local investment finance trusts are really joint ventures aiming to develop a market for private investors in primary care and community-based facilities. You can see it enables investment in new premises, in new locations. When this scheme first started, 60% of primary care premises were not purpose-built. 80% of them were below the recommended size and recommended standards. And so what this initiative has enabled to be done is new facilities. And you get modern integrated services in high quality centres. And it's essentially a joint venture between the Department of Health and an organisation called Partnerships UK, and the JV is called Partnerships for Health. A lift company is formed in partnership with the local health economy, the local primary care economy, and with the private sector partner, who again is identified through competition, which is really important here. And again, they enter a 20 to 25-year contract to deliver non-clinical services. The program started in 2001, and there are currently about 49 lift projects developed over 4 waves in the United Kingdom. An example is one, Oxford Infracare being the private provider, their partnerships for health with NHS Oxfordshire and the local authority, the Social Services Authority too. And they have a 25-year program to develop and improve community and healthcare facilities in the city. And there are various examples here, photographs of various lift projects which have been produced under the LIFT scheme. And then I should just finally say the whole question of suppliers. These perhaps are not private sector partnerships, PPPs, but they are working with the private sector. And it's just very important that I think the learning from this is it's very important if the National Health Service or the public sector is going to partner or contract with the private sector, it's really important that the public sector has proper commercial expertise and good negotiating skills to get proper deals. You can create great economies of scale if you do it right, but you have to be very cautious, I think, with incentives if you have these sort of schemes, particularly over time, particularly if it involves treatment and care. The trouble with financial incentives is that people will only often go for where the incentives are, and other things get left by the wayside. And it's very important if you have these contracts, my final point, on this slide, to have agreed arrangements for monitoring performance and determination, so that you know whether your private provider is delivering what is expected of them and can tackle them if they are not.
3 minutes.
So the great thing about these PFI and LIFT schemes is you get excellence in design paid for by private health providers. So I've explained that we have these schemes in the UK. They may be of interest to you here in Libya. I don't know. But what we can do is introduce you to the people who set up these schemes, to the private sector companies who are experienced in PPPs, and help maybe create consortia to meet specific needs if you have them. We have local UKTI support. I chair the healthcare business group of the UK Trade and Investment, and we can arrange missions and visits to support if you think that this would be helpful as you're developing the service. And these are just some of the brands of some of the organizations which are involved. Thank you very much indeed for listening.
Thank you, Mr. Owen. Let us start giving 5 minutes for the questions, because we should go to the lunch. But I want just to remind you, with the 3 lectures being given by Professor Sagara and Mr. Hola and Mr. Owen. First one was about the clinical services, and he was mentioning the plans of the health services and indicators of health, as well as the distribution of utilities and human resources quantitatively and qualitatively in the Libyan health sector. As well, he was giving hints about private clinic and private health sector provision in the Libyan health, as well as the training and the education in health in Libya, and also about disability. So Mr. Hola has given a differentiation or definition of the primary health care, as well as the and general practitioner, and she gave the definition of both, and she talked about accessibility and continuity, coordination, these the functions of the primary health care, as well as person focus in the system and advantages of primary health care. And also she talked about the GP, and Mr. Owen has been talking about the private-public partnership, and he showed some types of contracting between the suppliers and the national health system, as well as talking about some examples of that. So you can have questions. We can give the floor. The questions, who have the... Yes, please.
Would it be possible to use the PFI model, like using the private sector, which is very, very good role for solution?
Mr. Owen, please. Yes.
Can you know, during the revolution, the private sector,
Paul.
hospital.
Yes, microphone, please.
During the revolution, treating the wounded infection, we've got lots of private sector. So would it be possible to use the that model to help the primary health care for the time being, because we're passing it through a storming stage where we are lacking the primary health care. So like for 5 years, just to boost the primary health care. Would that be possible?
I mean, I think anything is possible. I was just describing what we do in the UK, and it works over the 25 to 30 years in that case, but I'm quite sure that there are private organizations who would be prepared to come along and to Libya to meet you and to talk about either shorter terms or how they can work with you. Yes, I think anything is possible. There's a whole range of different types of companies who would be interested, I think, to come and talk to you and assess your needs, and we'd be very happy to talk to you afterwards about how we think we might be able to bring those people to you.
My question is to the first speaker. Samir, thank you very much for your excellent talk and overall review
Professor
of the health
Samir,
service in Libya. My question is, do you have any information or data about the actual annual cost of the healthcare in Libya?
Assalamu alaikum. My question is to Mr. Owen. My name is Nuruddin Shelley. I work at University Hospital of South Manchester. We all know about the BFI private sector and the program, which has been, I think, running down in England. My name is Nuruddin Shelley. I work at University Hospital South Manchester. My question to you, BFI has been recently in the public media in England, and we all know how much it costs the taxpayer. The example of this recently is the St. George NHS Trust down in South London, which unfortunately is collapsing and has cost taxpayer probably, if I'm not wrong, £1 million per day, if I'm not wrong. What do you think went wrong down there, and what's the solution, and how the ball went wrong down there? Thank you very much.
I'm not an expert on what happened at St. George's, but I know that in the recession, it has been more difficult to have the money in the budget to make the payments, and that has been a challenge, I think. And there are not the same PFI projects happening at the moment for that reason. But I did talk about the advantages and disadvantages, and having to make those payments over the 25 to 30 years is a key part of what is required, and there is an agreement, and hospitals do need to make those payments. And in the early years, the private companies made very big profits, and in fact, in 2003, they agreed to give some of that money back to the National Health Service. But at the moment, it is quite a challenge, I think, for some hospitals. But I don't know the specifics of why St. George's is struggling. But generally, PFI has led to brilliant new facilities and very efficient production of care.
Quick question for
Last
Mr.
question,
Owen.
please.
What is the average? I'm here. What is the average lifespan of a partnership for PFI, particularly when you have capital costs involved? And can the government disengage from this partnership, or do you end up in court? Thanks.
Well, as I said, the payment periods, I mean, they are negotiable, but they're usually over 25 to 30 years. That is the lifespan of the partnership. The capital is provided up front, the infrastructure is provided, facilities provided, and then it's paid for over the next 25 to 30 years. So it's very difficult to get out of that agreement. If you want to get out of it, there would be a very big payment to pay to get out of that agreement. I don't know if Mike wants to. My colleague Mike actually runs a PFI. You better come to the microphone, Mike, just to cover off that point.
Yeah, Our agreement's over 35 years. Andrew's right, 25, 30 is typical. The key thing for us is that after 35 years, the PFI provider have to hand the facility back in grade 1 condition. Typically in the NHS, we've built hospitals and then neglected them because they've been built with public finance, then not enough money set aside to actually maintain them properly. Under the PFI scheme, the contractors are obliged to actually maintain the facilities at a certain standard. They are expensive, but I think there are ways to actually reduce the cost. I think it's very essential to have private sector involvement in design and build of hospitals, and it does make sense to have the private sector involved in actually maintaining the buildings, because they're not core strengths of the public sector or the health service. And we've had health service managers trying to manage buildings, and that's led to problems. I think the structure of the deal also needs to be appropriate, so the balance of risk and reward is there for both sides. And as Andrew said, over time we have become more sophisticated in actually reaching deals that get the right balance between public and private sector benefit. So there's a lot to be learned from the UK, and a lot of the earlier PFI schemes were bad deals for the public purse, but we've got a lot better at negotiating recently. Thank you.
Thank you very much. A couple of housekeeping points before we adjourn. First of all, we shall reconvene at 2:15. Try, please, to be courteous and prompt in arriving back. There will be certificates and some handouts at the last day at 6 p.m. on Thursday, so we encourage people to attend all 3 days. As a matter of fact, the didactics we had thus far is an introduction to the more important aspect of this conference, which are the workshops, and Dr. Saif Nasser is going to give you some blurb here, and then we'll adjourn. Thank you.
I see the interest here about the public-private partnership. So you can propose or prepare your proposal for some projects for the workshops, because you will. This will be one of the main activities of the workshops. So please do. Thank you. Thank you. We can.
And associated professor in the International Medical School in Benghazi. Dr. Adel Tajouri will talk about post-war assessment of the National Health Service. Please, Dr. Adel.
Mr. Chairman, سيد رئيس الجلسة والسادة رؤساء الجلسة، الأخوة الحضور، السلام عليكم ورحمة الله وبركاته. So I would talk a little about a survey that we performed in a few months, just at the end of the armed conflict in Libya. We all know that a disaster could occur anywhere. There are mankind or natural disasters. And what happened in Libya, we are not unique. Actually, we were late. According to other countries and regions of the world. And it all started on the 15th of February with the famous Wake Up Benghazi. The disaster, when it hits certain places, what happened? Mortality, morbidity, but also there would be increase in infectious diseases because of overcrowding, hygiene, and so on. And an important issue that we usually forget about are mental health issues that include a spectrum of things that could occur, and this spectrum either the initial fear and distress response, or a behavioral change, or a true psychiatric illnesses. And the impact of psychological on the community is even much more than the medical one. This is in our neighborhood where our children started only to play with Kalashnikov, and even worse, they are taking their friend to the grave. It's even worse. Playing with death is not an easy thing. Also, there are changes that could occur on the community level, not only on an individual level, as we have seen ravaging the cities, destruction like Misrata and Sir. And the number of those who disappeared were increasing at that time day by day. That we were talking about April 2011, and the targeting the infrastructure, including water, electricity, and so on. Of course, there were so many movements with different directions at different times, and when people move, the largest was in Jdabia region, and in this region there were about 100,000 population. In one day, they went outside of Jdabia and putting a real burden on the health services, because they would need of course, lodgement, they would need sanitations, drugs, electricity, water, and so on. Of course, we don't forget the local pathologies at that region that was full of scorpions, for example. So, at that time, in April, we decided to do, with the Benghazi Medical Center, with the aid of the Arab League and the United Nations Population Fund, we decided to make a survey and try to assess what happened exactly in Libya at that time. So the study was done between September and November in 5 different regions for the residents, and also for the internally displaced and externally displaced from the west to Tunisian cities like Jerba, Jarjis, Tatawin, and Medellin. We took around 5,000 families there, and that included the study more than 25,000 populations. Third were less than 15 years, and 3.9 of them were more than 65 years of age. 12% had a chronic disease that needed drugs, treatment, and 4.4% were handicapped. And these handicapped, 15% of them, the handicap were due to the armed conflict itself, and which makes around 1.1, roughly less than 1% of the whole handicap in Libya at that time were due to the armed conflict itself. 1.2, especially in the western mountains camps, externally displaced to Tunisia. In the internally displaced in the eastern regions, 57% had diarrhea. 33% they were living on human aid. 60% they found that they didn't have enough resources, financial resources, and around 1/5 had problem with water, medicine, and food. The best of the services that were maintained were the obstetrical antenatal health services. Around 85% were seen by doctors. And unfortunately, for children from 12 months to 23 months, around 57% only the coverage, which is a drop from the more than 92% average coverage that was in Libya before the. Those, as usual, there were a slightly increased incidence of diarrhea 2 weeks before the survey in the eastern region, in the eastern camps. And as you see here, the best services delivered all over, not only in the ORS, but also in mental handicap, were the western mountains, internally displaced to Tunisia, actually. So our colleagues in Tunisia were doing a better job than us. So 78% received about ORS, they received ORS. And if we see also here, again in Tunisia, the medical consultations, even for lower respiratory tract infections, was higher in the Tunisian camps. There are many symptoms that could indicate stress, post-traumatic stress in children, like difficulty sleeping, fear, increased anxiety, crying without reason, and so on, and including uncontrolled urination, night urination that started between 3 to 5 years of age, that started during the armed conflict itself. As in whole, 58% of children at that time, they were showing symptoms of post-traumatic stress. And only the best was in Tunisian camps, where 37% they received psychological consultations. In all others, whether they are residents in the eastern or the western part, or they are internally displaced, they didn't have a good psychological consultations at all. 3% they were exposed to violence, especially for those who were displaced to Tunisian camps. Most of them are from Nafusa Mountains, 10%. And this handicap in 18% of cases led to moderate or severe disability. And again, in the Tunisian camps, 28%, they received psychological support for the physical violence. And in other places, even including, for example, in the eastern mountains, in the eastern camps, in Benghazi, Jdabia, and Green Mountains, only 5% they received psychological. 8% of families investigated, surveyed, had somebody who either died, disappeared, or prisoned. And especially in the eastern camps, internally displaced, 15% of families. That rise actually after the immigration, the displacement of Taurga citizens to Benghazi. And the last slide will show that in adults, among adults, not children, 89%, almost 90% of adults in Libya showed some form of post-traumatic stress symptoms, at least one symptom, and that doesn't indicate the severe. 20% of this would be 17%, which is exactly as the expectation, the extrapolation that was done in a nice study that was published 2 months back from the WHO experts. Around 17 would mean severe mental post-traumatic stress. And again, those who consulted a doctor in Tunisian camps, higher than the other regions, or they received drugs like diazepam because they asked for diazepam themselves at all time. Now, I left the survey. It's outside. I cannot present the whole survey, but it's outside in the registration desk. You can ask for a copy, or in الوطني Libya, I'm trying to collect the all surveys from Libya, even the PAP child, the PAP fam, the school health survey, and putting them. So you have a PDF file of the Libyan, of the Arabic, and the English language. And if you need any question, you can ask in either these surveys or the صحة الطفل, child health and nutrition, or send to my email. So I'm ready for any questions. Thanks.
Thanks very much, Dr. Adil Tajuri. I think we have time for 3 questions.
You can always ask, if not now, afterwards.
No questions?
I'd be happy to receive the comments so that we can increase the effectiveness afterwards in next surveys.
Yes. Yeah, go ahead. Yeah. Okay.
Luckily, Dr. Fahmy is here. Help me, please. No. Okay, so the questionnaire is a standard questionnaire. We did not invent the questionnaire. We used a well-recognized, accepted international tool that was done by a professor who already did this in Iraq, and she works in the Red Crescent Cross in Geneva. And this is a well-standardized questionnaire that have been seen also by Dr. Fahmy before implementing the survey. And the other thing, we are talking of those who showed even one symptoms of post-traumatic stress. But the problem is that this is not really a disorder. There is a spectrum. Dr. Fahmy would know better than me. I'm not a psychologist. And in this spectrum, you have the severe case. So even if you work more than before, if you don't sleep well, if you try to forget, these are symptoms of stress, post-traumatic stress. And I probably think that we underestimated the prevalence rather than overestimated the prevalence. But the severe cases are 17%, and it comes exactly at the extrapolation of the WHO expert group.
Okay, Dr. Rida.
Thank you. Thank you, Adil, for the presentation. I would like to find out, this was a cross-sectional study. Do you think you will have follow-up from there to see, because at the time of the study, this was the peak of the problem. You think this would have settled by now in the large majority?
Yes, actually, that would need a few years, and some of them wouldn't settle at all. So what we were supposed to do at that time, we still have a time, well, we had to do more a survey that include all over Libya. We did not include all over Libya because at that time it wasn't all liberated. So we should do a national survey, a survey that is more comprehensive first. The second, other follow-up studies in mental health, because this is important. But even more important of all, we have seen that the percentage, the proportion of immunization decreased to less than 80%, 60%. That means we were supposed to have immunization days to cover up. I don't know why didn't this happen. Some other experts think that no, our figures are exaggerating. I don't think so. I mean, they have to prove it that the immunization coverage is still 90% or more than 80%, and we could only do this with a survey, a real survey, that wasn't done. And the survey for immunization coverage doesn't need anything. Only 30 clusters with 7 children. In each cluster, it's a 1-week job, and if the ministry decides to do this, then it would be easy to do. Actually, that didn't happen.
Did you reassess, Adil, your...
No, we had the budget from the United Nations Development Fund at that time. And
another assessment to see if they're recovered from the post-war remedies.
No, actually, we tried, but we did not succeed to have extra budget to do this, especially for children. That is my interest. And to do them and to make community-based interventions with group psychotherapy and to see the results afterwards, to see, because the proportion of those who are affected cannot be managed in a hospital or in health facilities. So community-based interventions are needed really to overcome this, to tackle this problem at the community level. And we were trying to do whether is this really useful and effective? Is this evidence-based to know whether this happens or no? Unfortunately, we could not have enough money to cover for the service.
Yes, go ahead, yeah. Yes, there.
Yes, for those who are residents in the country, of course, we pick up from the, according to the number of population, it's a self-weighted sample, and 2,500 were picked up from these 5 areas with residents. And then we took 2,500 families from the camps. Thank you. I disagree with you. It means something, the figures, but of course, interpretation of whatever data you have or the information that you got, and you cannot treat them equally. We all know that the immunization coverage is 92% in Libya of children. So if I have 56% here, I don't have to do, it's not a must to have a similar survey and repeat the survey afterwards. For the mental health, yes. Is the post-traumatic stress is from the trauma of the armed conflict or from the trauma of the governing of Gaddafi during 30 years? I cannot know. You are right in this one.
Dr. Samir, go ahead, please.
I want just to say that this survey had the most important impact in terms that it happened just in the post-conflict era. So it has really taught and brought a lot of indicators that we can build on. But at the same time, there was another survey which is countrywide, done in 2007.
Yes, the PAPFAM in 2007.
And now there will be a follow-up one, which will be countrywide as well, that we are discussing as UN with the Ministry of Planning and with the line ministries, including the Ministry of Health. And maybe if we take the trend of 2007, the work that we have done, and now the new one 2 years after the conflict, it will give us a much better idea about the trends in the Libyan society as far as the indicators have been started by the government.
Absolutely, Dr. Samir, I agree. And I put in the group in Facebook the Libyan national surveys. So I put the PAPFAM of 2007 and the PAP Child of 1995. and the school health of Mr. Mohammed, he's here. So in order to make this comparison, for the immunization coverage, it's there, but nobody looked for post-traumatic stress at that time. That's the issue.
Thank you very much, Dr. Adil, for this interesting. Still, Adil, I have
a question for me. Yes, but you can ask me afterwards.
He's running away.
By the way.
Adil, thank you very much actually for this interesting presentation, and actually I'm really glad actually to see this actually as presented to this prestigious conference. Data is really very important. Assessment is something that actually I've been always actually fan of, and a couple of colleagues are sitting here. Actually, we were sitting together in the humanitarian platform actually during the hard time in Libya. We keep always on talking about the assessment, and I'm very glad actually to see at least preliminary results of this. My question now actually, you were aiming at actually getting out, come out with the recommendations. One of those actually, you highlighted the issue of the psychosocial support. Mm-hmm. What was your recommendation actually? What you want exactly, to say in this actually? Because during the hard time, I keep, and couple perhaps maybe supported my argument at the time, that I keep always arguing that we never needed aid, food aid. Despite the fact that everyone was pumping us with a food aid. At that time, we never needed a food aid, but we needed actually a sort of a capacity building and a psychosocial support. So this actually, this actually supported the argument that indeed, the psychosocial support left behind important subject. You highlighted that, and you urged it for you urged to come up with the programs. To support the traumatic or the affected people. The second thing, actually, I didn't see here a mention of the IDPs now in Libya. Perhaps maybe Dr. Samir was mentioning them. What are you going to do with them, actually? The IDPs now, the affected IDPs who are actually, scattered everywhere in the country. Yes. Are they part of the study or not?
Okay, so I would start with the second question.
Yeah.
Now, with the problem, even if you check the number of families that had somebody who was affected, 15%, that was the highest. And this represents really a biased sample, because at the beginning when we did this in August, Taurga and Misrata, Taurga was not really liberated at that time. So the IDPs at that time were from Brega and the middle of the country. And the figures were different. When we put them together, actually, maybe we need to disaggregate the data more than this. And Taurga were also involved. Apparently, the number of the proportion of families who had somebody who died or disappeared is much higher than the rest of the community. So we imagine that the stress also is much more. I think that they have problem now with schooling, and you are put in a camp in a chronic way. It's a problem. That would be an issue, even a place for crimes afterwards, and then everybody would be upset. Doing nothing till now for almost a year is a mistake. It indicates that there's no planning, no vision, and we are not doing our job rightly. So this issue has to be solved. Otherwise, the social impact would be much more than this. The second, the first question you pointed about nutrition, for example. The problem with psychosocial support, that the infrastructure of psychosocial support already is weak in Libya. 14 psychiatrists in the whole country for a 6 million is impossible to solve it. Even in countries like United States, when Katrina hit the coasts of the states, because they had 2 million displaced at one time, it's impossible to find psychiatrists and psychologists and sociologists to see all these at one time. So the community-based interventions, where we do group therapy with people who were trained only for 4 or 5 hours, is a good solution. And luckily, Professor Stanford from States, head of psychology department, he said that he trained some other people to do this. And we are trying to train people to do this, social volunteers only, not more. But we were not supported really from, I'm criticizing the ministry, because I think the vision of those who are in charge in planning in Libya is very narrow, it's very limited. They wouldn't take this at that time. even
Time عادل لو سمحت.
I'm answering the questions. It was, unless you don't want me to criticize the ministry. That's something else.
آخر معلش كومنت بسرعة الدكتور فهمي بهجت.
More details during the presentation I'll be presenting now. Thank you, Dr. Adel, for this very interesting presentation and this very good work. As a comment for the colleague who mentioned that it might be an exaggeration that we see 89% or 90% of the people having psychological distress symptom. Actually, I don't think it's an exaggeration, because the study doesn't say that these people have an illness. It says these people have psychological distress symptoms. Actually, I'm surprised maybe why not everyone is having 100% of psychological distress, because if you are exposed to an event where you lost a family member, you have left your house, you are exposed daily to the sounds even of the armed conflict, everyone will have a psychological distress symptom. If you look at the type of the question the study was asking if you're a person having an anxiety feeling. If you don't feel an anxiety in the middle of an armed conflict, I would be worried about those who don't have symptoms, actually, not those who have the symptom. But according to Dr. Al-Awkali question about what about after one year? Would these people have actually, according to the projection and the evidence we have, we would estimate that maybe about maybe 20 to 24% of these people might have residual symptoms and might be reaching a level where they are diagnosed with a mental illness that would require intervention. But definitely not everyone. Definitely not the 90% would need treatment. They would require family support. They would need the help of their peers. They can many of the symptoms will resolve. Many of the community members will show resilience, but definitely not the 90% would require treatment. Thank you.
An important thing about the interventions, other than the group psychotherapy, are parks where mothers could go with their children safely and stay there, and the children would play in the city. So a city like Benghazi with 45 so-called gardens, but these are not really the parks we were talking about. It's unlikely that we would come over to counteract this epidemic, if we could say.
Thank you, Mr. Chairman. With the permission of the chairpersons, actually, I would like to invite Professor Al-Hadi Al-Aburawi, as a graduate of University of Tripoli, 1981, second batch, mashallah, consultant pediatric cardiologist at UAE University Hospital. He is a holder of a couple of abbreviations. I'm not aware of ما نعرفنش يا دكتور سامحني. FACC, FRCPCH, FRCPI, and PhD. Dr. Aburawi is going to deliver his presentation on emergency service assessment.
Last March. It's by chance that I have been invited to join a group of experts from England, United Arab Emirates, and we came over here in March, early March, after the request from Dr. Fatma Hamrouche to assess the surface of the communicable disease and non-communicable disease, plus the emergency service or the ambulance service, if I'm right. So this study was done in early March, and surprisingly, that actually there is nothing you can say there is any kind of ambulance service available in Libya, and I'm sure most of us we know that, and just this is the confirmation, like what exactly we have on paper after confirming or after having evidence for what exactly we have. There's no conflict of interest with my colleagues, Professor Mohammed Sadiq from the United Arab Emirates and Alan Kennedy Pulam from the Institute of Remote Health Care in England. And just for a view of my talk, trying to what is available in Libya. and the introduction to the emergency care in general, and then the objectives of this field study that done in March 2012, plus sort of results, that's what I have got, and then a few recommendations as a response of this study. If I ask the audience here, do you know that Libya has any kind of central emergency telephone number? No? Yes? It's actually there is 191, and it's not functioning. So the number is there. You ring, maybe no reply at all. You may get, maybe 1 to 2%, you may get a reply or answer. But according to the study, I'm going to come over there, saying that the minimum time that could the ambulance come to somebody who has heart attack in the middle of Tripoli, in the city itself, takes 2 hours. So you make a decision. I'm not having the final decision like what exactly we have. So this review of the Libyan ambulance service field study is a product of expert observation and advice following the organizational review. And this field audit of the Libyan ambulance service, LAS, I will follow this abbreviation which is Libyan ambulance service, during the second week of March 2012. And the Libyan ambulance service team responded to review questionnaire. That's like an introduction of what is available. Like injury is a major cause of premature death and disability worldwide, and everybody knows that as basic information. The prompt provision of emergency care and rapid movement of injured victims from the scene of injury to a healthcare facility is vital. It can save lives, reduce the incidence of short-term disability, and dramatically improve the long-term outcomes. Most existing injury control strategies focus on primary prevention. Currently, the capacity to provide this basic level of medical care does not exist in Libya in any definitive or qualitative system. An effective pre-hospital trauma care system should be simple, sustainable, practical, efficient, and flexible. Pre-hospital care should be integrated into the Libyan Ministry of Health, new healthcare, public health, and transportation infrastructures. The pre-hospital trauma care will form the foundation for all Libyan emergency care. It will quickly be tasked with the responsibility of addressing a broader range of health concerns. This includes pediatric, adult medical, obstetric, and obstetric emergencies. The objective of this study to accelerate the comprehension of an on-ground situation and corporate information supplied by the Libyan ambulance service to provide advice to prevent injuries, to alleviate the injury consequences, and enhance the quality of life of Libyans. The results is actually could be surprise for everybody, I'm sure, that there are 500 drivers and only 50 ambulances in this center of, everybody knows, in Sab'a, called Sab'a, which is about 7 kilometers outside Tripoli, and there are 30 nurses and 10 doctors. The Libyan ambulance service don't have even the most basic data on patients' outcome. There is no clearly defined strategic directions or policies. Libyan ambulance service personnel have no clear job specifications and therefore are currently demoralized by lack of progress and direction. There was no evidence that clinical staff have any knowledge, experience, or education in the pre-hospital environment. The system of communication is ineffective, even though it was in archaic language. Sorry, should be in Arabic language, sorry. Ineffective, even though that was in Arabic language. The ambulance vehicles are unserviceable due to lack of parts and knowledge and skills that need to be arranged or done by the fleet engineers to repair and maintain the fleet. No coordination between pre-hospital and secondary care, and precious clinical resources are being taken, or maybe stolen, you can say, but taken from the regional hospital by doctors acting as escorts in ambulances. This denotes the hospitals of key clinicians whose role and needs is in hospital. And there's no coordination between clinicians working in trauma, cardiology, anesthesia, and relevant specialties with clinicians in the Libyan ambulance service. The Libyan population believe there is no Ministry of Health ambulance service in Libya. The central emergency telephone number, as I said, 191, is not recognized by the public, and the public have no faith in making emergency calls, as they perceive they will not receive any response. Ambulances are in the wrong location, and the aeromedical service is not available. There's no duplication, sorry, there is duplication in resources with the Libyan ambulance service and hospitals, as each hospital has ambulances as well as the center for the ambulance service, and both having ambulances to fulfill the same purpose. No employee accountability, with a belief that the financial department and management are blocking any kind of progress. No operational protocols, standards, and metrics. No systematic training policies or curriculum. No clinical audit or outcome metrics. So this is likely what we have found, and it was not, for me actually, it was not surprising at all, because I've been working in Libya for 5 years, between 93 and 98, in the cardiology department here in Libya. And I know that, but maybe for somebody else, that not the extent that actually level or the extent that we have for the ambulance service. So we put some recommendation to the Ministry of Health in March, and until now there is nothing done. Design and implement a clinical governance framework which will monitor and audit clinical outcomes and continuous improvement. Develop logistics expertise to drive efficiency in vehicles and manpower utilization. Establish clinical protocols which match skills level and deliver improved patient's outcome. Develop a faculty of pre-hospital emergency medicine, and in conjunction create a modern Libyan ambulance training center. Train all operational staff in the basic life support. Train clinicians in the advanced life support and trauma management and disaster preparedness. Reintroduce and develop the aeromedical wing of Libyan ambulance service to ensure timely response to incidents occurring in rural locations and high-density traffic situations, and introduce a community-first responder system to create immediate improvements in patient outcomes to road traffic accidents and serious trauma incidents. Thank you very much.
Thank you very much, Doctor, for this interesting presentation within the time frame. Now we open the floor for a couple of questions, comments.
A quick addition to your, thanks very much, Adil. Yeah, I just want to add that, the ambulances are very, very badly misused. They are used for ordinary transport of anything in the hospital. Communications, taking of blood samples to the labs, and very badly misused. And we can't prevent this. We could not prevent this.
Okay.
Right. Okay, yeah, any question?
اللجنة الدولية الصليب الأحمر. صوت لو سمحت يا منعم.
Morning, my name is Abdul Badiah. I just want to comment on something. What do you think about the securist, or about the volunteer, or about what we call the first aider? Because it's not also exist in this country for the ambulance drivers. Because if you have only the ambulance and you have drivers, even the drivers, they didn't have any minimum idea about the first aid for the patients. Thank you.
دكتور ناخذ مجموعة أسئلة وبعدين نجاوب ممكن لو سمحت؟ Okay, okay, go ahead. Yeah, go ahead.
Medical education and professionals as well. This is very important, of course, but we should have the basic level of at least the basic level of the service from the point of view of the equipment, cars, all the infrastructure, you can say, and then we can sort of train, and we need to have also paramedics as well to be trained for the job. And the job of paramedic is actually, it is very, very, very well needed in our country. We had also discussion, just maybe extend a little bit on this answer, that we have a discussion, who should we recruit for the paramedics in Libya? As you know, faculties, they have thousands of students they have been in the faculty of medicine for 10, 15 years, 20 years, some of them. Should be used? Should we use the what do you call it? The medical technology or the Institute for the Medical Technologies, especially the anesthesia department, like who are specialized in anesthesia. Who should we recruit? And I just also mentioned that we probably need a pre-hospital faculty or pre-hospital medicine faculty to train them for 2-3 years probably, and then give them a higher sort of diploma or whatever for these paramedics. We need it. Our area, our country's area is sort of more than 2 million square meter, and to cover the whole country is not an easy job. I think this is one of the priorities for the Ministry of Health, or for us, that something should be done.
شكرا دكتور. الأستاذ الكريم لو سمحت اسمك. This is a good opportunity for networking. Your name please.
Yes.
So
you can come here if you like.
It's okay. My voice is loud anyway.
Yes.
Thank you for a nice presentation. It highlights the problem, which is very big. Actually, my question is not pure question, is also a suggestion. You asked just now in the answer of the previous question, who should be to initiate the emergency medical service. From history, we know that the military is the initiative for emergency medical service in the USA and in United Kingdom at least, especially in the United States. The emergency medical services started in the 70s, or in its current form, in 70s by an initiative from the military health, military emergency staff. So we need emergency medical services which is highly disciplined, excellent in communication, excellent in obeying orders. In the current situation in Libya, I don't think an emergency medical service personnel will be sitting in the ambulance waiting for a call, or somebody waiting for on the headphone to answer a phone. The number you mentioned there, I personally tried several times. No, there's no number exactly. Sometimes you're faced with a toot, that's it. So what I'm suggesting is to involve, in addition to the Ministry of Health and the emergency or the ambulance service in Libya, is to incorporate and try to incorporate the military staff. And also, some of the doctors, the young doctors and nurses, volunteered during this blessed revolution of ours, during the war. They created an emergency medical service. And they probably can continue, and we can recruit them and use them in creating an emergency medical service rather than an ambulance service per such. Because now emergency medicine is at home. You can do the resuscitation. You can save the life at the scene of an accident. So it's just a suggestion, and I wish to discuss it further in the workshop. I don't know what you feel about that.
Like the basic life support can be we shouldn't ignore the ambulance service. The heart attacks, I mean, that's one of the common cause of death worldwide anyway. And at the moment, there is no if you are lucky, that could somebody by taxi or from one of your family could drive us or one of our families to the hospital, which could die in the way, and there's no anything could be done. The area that I come from in Dubai and in the United Arab Emirates in general, I mean, the minimum time that 5 minutes. If somebody had a heart attack in Dubai or in Ain or in Abu Dhabi, 5 minutes that the patient should arrive to hospital. And once he's ringing, or the family, one member of the family ring by mobile phone, they know where is he, and no need for any by the GPS. They can go direct to and collect him. At the same time, once they put the ECG leads in the patient's chest, straight away the ECG will be transmitted to the hospital, with the nearest hospital, and at the same time the patient will be, I mean, the doctors will prepare and they can advise what kind of job they will do. So why don't we have it in our country? We have the sources, we have the personnel.
Thanks, Doctor.
Yes.
I mean, I strongly support the previous two comments. Actually, I strongly recommend to add the element of a community-based first aid. Actually, training. I mean, to reach out. السؤال الأخير لو سمحتوا لأن حسب التشيرمان قال لي سؤال أخير وبعدين ربما في فرصة في الكوفي بريك. أستاذ لو سمحت اسم حضرتك.
يس خالد المغبوب مدير مستشفى الأطفال طرابلس. First, just to remind you that many vehicles have been used during the war and never returned back to the Ministry of Health. That's why the number of vehicles is just 50. Your recommendations, there's nothing much about recommendation in the system itself. Now in Tripoli, there is a center for ambulance vehicles, and when the hospitals need a vehicle, they have to phone this center, and there's a lot of problems. Do you think this way will work if we improve the personnel and the vehicles, or do you think each hospital should have its own vehicles, or maybe we divide Tripoli to many areas like Suq al-Jum'ah, Tajura, and every area, every town has its own ambulance services system?
Yes. Answer to the first part of your question, Khalid, that actually, there are many ambulances, and I'm aware of, and my children who are in Sweden, they have sent a lot of ambulances from Sweden, from Spain, from England, from Ireland, from all over such countries and European countries. Ambulances came over. But what we have, the number that I have here is that the data or the number of ambulances that they have even before the revolution. So this is one thing. I know there are many lost somewhere. But regarding the plan, I think I recommend probably we should have workshop about this. Decision, of course, I cannot make the decision, but there should be something on the ground that how we can divide the cities, like the capital itself, I mean Tripoli, that could be divided into certain parts because of the crowding and the roads are very, very difficult to drive. I mean, if you come now drive to the city center, you take at least 1 hour. So that's one thing. And the other thing that we could help the ambulance cars, like with the helicopters, which could have areas like near the Grand Hotel on the sea,
دكتور لو تسمح لي ممكن
and so on like.
Excuse me دكتور ممكن نناقشوا هذا في الورك شوب لأنه مازال في 3-4 presentations. أنا آسف حنسكر الأسئلة هنا لأن أستاذي أعطاني تعليمات وأنا ما نقدرش نرد كلمة لأستاذي وبالإضافة إلى فيها 3 more presentations يعني.
Thank you very much. Let's take a quick announcement, please.
السلام عليكم. في شوية تعديل بس في الأجندة متاع بكرة إن شاء الله. Health governance, instead of it's going to be in the morning, it's going to be in the afternoon. والمورنينج حيكون في بإذن الله health service delivery. حيكون في 1 hour of workshop, and after that followed by a workshop discussion for 1.5 hours. And after that is going to be a recap of the discussions for plenary sessions. A roadmap and how we conduct the workshops is going to be slide presentations during the morning, inshallah. Tomorrow we're going to start, inshallah, around 8:30, like every day. And during the 1 hour also, as I said, there will be a slide presentation. بكرة إن شاء الله الورك شوبس صار فيها تعديلة بسيطة اللي هي توزيع الخدمات الصحية حتكون في الصبح، والهيلث جوفرنس حتكون في الافترنون، وحيكون في توك لمدة ساعة، بعد تالي حلقة نقاش إن شاء الله لمدة ساعة ونص، وبعد تالي حوصل للنقاش لمدة الساعة الأخيرة ما قبل الغداء إن شاء الله. السلام عليكم.
شكرا. دكتور فهمي بهجت, please. Dr. Fahmi Bahjet is currently working as a mental health advisor to the WHO office in Libya since December 2011. He's a consultant psychiatrist from Egypt with postgraduate degrees in psychiatry, mental health, legislation, and healthcare management. He worked on mental health advisor and healthcare expert and a planner for vulnerable groups in emergencies in several countries of the region, including Syria, Jordan, Iran, Egypt, Saudi Arabia, and Palestine. He is currently based in WHO office in Libya, precisely in the CDC. Dr. Fahmi Bahjet will talk about strengthening mental health